Yes, sir.
All right, so we can go to the first slide here, and I'm going to have to point in advance. No, come on, do this. All right, so Keith and Sam, go to it.
All right, so this case was a 75-year-old man. Basically, he came in with moderate blurred vision over the past several years. Not on any kind of specialty meds. His medical history is significant for high cholesterol, high blood pressure. He's at the starting stages of dementia, and he's on Hawthorne herb and some multivitamins, no known allergies. Visual acuity is kind of moderately decreased at 2063 in the right, 2050 in the left, and the IOP is slightly low, but normal low at 9 in the right and 7 in the left. Next slide.
So what do you see there, Sam?
All right, so color fundus
point.
photo of the right eye. I was really hoping this was going to be a cataract, but it looks like we've got some retinal pathology going on. The vitreous is clear. The disc is completely normal. Your attention is drawn to the macula, which has some yellowish deposits parafoveally, possibly inferior to the fovea. There's also some yellowish deposits along the inferior arcade. Otherwise, everything else looks pretty normal. Same in the left color fundus photo, except we have some pigmentary changes temporal to the fovea as well, some dark spots, but otherwise similar picture.
If you had to put a color on those, would you call those, what color would you use without me
Like
telling
black.
you the color? They're kind of black, don't they?
Yeah.
I would use black too, which is of some importance.
All right, so some IR photos. What was that, hyper reflective?
Yeah, use the word hyper-reflective.
Yeah, so hyper reflective spots where the yellowish pigment was in both eyes. That's really all. And is this autofluorescence?
Yes.
Why did
And-
you turn those on?
You want to give me a line?
Yeah.
The other one was giving me a line.
Why would you turn everything down? Am I wrong?
Which I don't like it totally darker, but
Yeah, so there's some hypofluorescence, especially in the left eye, in the macula.
okay.
And so here we have an OCT of the right eye. Let's see. So I guess I'll start from the vitreous looks clear. Not sure if there's a partial PVD. No, there's maybe sports disc. And in the retina itself, it looks like the outer retinal texture may be a little bit, I don't know the word to use, maybe disorganized outer retinal layer.
Yeah, perfect. Disorganized is good.
And maybe to the fovea and the disc, maybe the inner retina also has some swelling and some deposits in it as well.
Middle retina's a little funny there.
Yeah.
But yes, perfect. Nice. That's a vertical line. The other one was horizontal.
And so here we have some deposits also within, looks like the internuclear layer, but otherwise nothing really. So this is an OCT of the left eye. This one has some more pathology going on, just as there were in the color fundus photo. Here we have some deposits in the outer retina as well. Casting some sort of, do they call those like, if they cast, not a shadow, but is there a word for that?
Well, actually, that is kind of shadowing. So we
Okay.
talk about reverse shadowing. So in
Reverse.
between, it looks like reverse shadowing. And then
Yeah.
in there, actually does look like a little shadow maybe.
Yeah.
And that's the vertical cut.
Yeah. So, similar picture, more
I think that might
interretinal.
be it. Is that the last picture? Yeah, that's it. Go back to
All
the color. It's kind of interesting. All right. So what do you think? What are your
All
differential
So
findings?
75-year-old male, bilateral, vision changes. He's got some deposits in the macula, OU. Some of the deposits are in the inner and outer retina. I would think maybe some MacTel, maybe. Differential could also include ham, although usually the deposits are immediately parafoveally.
That's good. And then any other diagnoses or just that you come up?
Neuroretinitis, maybe.
Yeah, good. I would think it'd be interesting to talk about crystalline retinopathies because those are more crystals than anything else.
Yeah.
You don't have
Yes.
enough crystalline retinopathy, do you? You know a lot.
So like talc and other medicines, but I didn't see anything in his medication history that could cause.
Yeah, there's like
crystals.
Beatty's crystalline dystrophy, and
Right.
there's that one in Africa that colon nuts people thought, but maybe not. And yeah, so there's not a lot of things. And so MacTel's kind of at the top. Nice. It's interesting because the OCTs are not the classic MacTel OCTs. You don't have those voids.
Yeah.
Which is kind of interesting.
So the yellow spots, some of them are probably crystals, but you think some of them are exudates
I think they're all crystal.
all the way
Yeah,
around.
I think they're just crystal. This is the most crystal. I love this case.
What kind of crystals would they be?
I don't think we know. I think the thought is that they're the Mueller, they might be the Mueller cells. Not the foot plates. I guess they're foot plates on both sides. I want to say head plates because they're on top. But I think they're thought to possibly be the Mueller cell degeneration.
So you still do the prescribing of syrup?
Yes, serine. And then the other thing on this one is if you have in your head somewhere normal autofluorescence, this is totally missing the dark spot. So you should have a dark spot in the middle. This is missing it, and this one, it actually looks almost opposite because the retina started been damaged. But
It's actually a bullseye.
yeah, but the dark spot's totally missing, which is a MacTel thing. So that even though this left, even if they didn't have crystals, that would be like a MacTel thing because they don't accumulate macular pigment for some reason. All right, Keith, I'll let you do your talk since I started.
Why didn't
All right.
the systemic pain in the OCT?
Like the island draping?
Yeah, they
That's
just,
what I was so used
yeah, it just didn't, they didn't have that.
to. Weird.
Yeah, I know, this is sort of a little bit atypical. Go ahead.
All right, so you did a good job with all the findings. I pretty much summarized what you had said on this slide. So we can go next slide. And then you said a pretty good differential. This is what I had kind of come up with as far as differential, but we can do next slide. So you got it right, macular telangiectasia. So
Good job, Sam, by the way, very well done.
Thank you.
You have a remarkable fund of knowledge.
especially with the fact that, you know, the OCT on this wasn't, you know, so characteristic. It didn't have that specific excavation that you normally expect. So good job. So I do talk a little bit about MacTel. Now there's 3 different types. So MacTel in general is a group of disorders characterized by non-perfusion of ectatic and incompetent retinal capillaries in the parafoveal region. There's loss of outer nuclear layers and ellipsoid zone layers that can be that progress to cystic cavitation, or eventually full thickness or macular hole or subretinal neovascularization. Next slide. So I break down the 3 different types. Type 1's a less common one. We don't hear as much about this one. It's thought to be a variant of Coates disease. And they have congenital retinal telangiectasias in the temporal macula. There's lipid-rich exudation that can form at the margins of the telangiectasias, and the symptoms are usually in like the 3rd decade of life and come about due to macular edema. One of the things that ophtho questions, I think, mentions about MacTel type 1 is that focal laser is effective for MacTel type 1 because of the leaky vessels, whereas it's not effective in the other ones. We don't really do focal laser, but that's one of the things that ophtho question seems to think is relevant. Next slide. So then MacTel type 2, this is the more common one. This is the one we might actually end up seeing at some point. It usually presents in the 5th to 7th decade of life, so a little bit later on. And this patient was, you know, a little bit on the older side. hypertension and diabetes might be risk factors. So in these patients, they demonstrate symmetric, usually temporal, small parafoveal areas of capillary telangiectasias. In the early stages, these might appear as like a slight graying of the parafoveal retina, loss of the foveal reflex, and as it progresses, RPE migration occurs and you get black pigment plaques, typically at right angle venules. And then one of the things that like the book and then a lot of resources say is that there's a lot of these things about right angle venules, especially on FA. I didn't feel like that was super apparent in these images, but that's one of the things that a lot of stuff online seems to think is relevant.
Hop back real quick, hold on. The right angle venules are a little bit confusing because they're not, it's not actually a right angle. The right angle they're describing is actually where it dives into the retina. So it's not like you see this and then a dog leg. It's actually, you see where this one truncates?
Mm-hmm.
You got a venule there that just kind of stops. That would actually, my understanding, which I think is correct, is that that's considered a right angle venule. Because the venule stops and then it goes to a right angle down into the retina.
It's interesting, you didn't get a forcing, did you?
Nah.
Yeah.
But I have a couple of them, but so the right angle venial thing just drives me crazy because it's one of the worst ones. There's so many things in MacTel that are helpful, and that's I think the least one. The other thing is that black pigment, because it's actually pigment migration. It's like what you'd see in retinitis pigmentosa. It's where you have loss of outer retina and pigment migration. So it's almost the bone, it's almost a bone spicule next to the fovea, which is totally different from macular degeneration. I had early in my career, I had a patient from Chicago. She was a snowbird. And I was seeing her and calling it macular degeneration. She saw Lee Jampol and he said it was MacTel. And I looked at her, I said, oh gosh, you're right. It is MacTel.
He's always right.
But yeah, Lee Jampol's always right. Okay, where are you up to, right? Yeah, right.
Next slide.
Okay, perfect. All right.
Okay, so yeah, so a little bit continuing on type 2. So FA shows temporal foveal telangiectatic vessels that leak in later stages. Evidence of venal, like you just mentioned, evidence of venules diving at a right angle into deeper retinal layers can also be seen. There might also be decreased foveal hypofluorescence secondary to loss of the foveal luteal pigment. Areas of RPE hyperplasia appear as hypofluorescent spots. Next slide. And then as far as OCT goes, it shows temporal foveal pit enlargement secondary to loss of outer nuclear layer and ellipsoid zone that can progress into large cysts that encompass all retinal layers. These are thought to be due to missing cells creating a void rather than like actually fluid in that area. So normally if you see like a darker portion on OCT, you think fluid, but in this, it's more just that there's no cells there. Oftentimes, so like if the ILM is the only layer left, that's when you get this ILM drape. And then hyperreflective areas on OCT correlate to areas of RPE, hyperplasia, and migration. So another thing of RPE migration. And next slide. At the end stage, you might get subretinal NV arising from the retinal vasculature. And at any stage, you can get these superficial retinal crystals that we saw. That was, I felt like on our imaging, that was like the most striking thing to me was all the retinal crystals. So I thought that was kind of interesting. There's no effective treatment, but if there is NV, you can use anti-VEGF to treat. And then the visual acuity in this one, usually it's not too bad. So half of patients have 20/32 or better. And the mean acuity is 20/40, but you can get really bad vision if there's like a full thickness macular hole or subretinal NV, so 20/40, 2200 or worse. Type 3, I couldn't find a lot about this. I just saw that it's a thing, and I saw a few case reports about it. But some of the stuff I was saying was essentially rare, poorly understood. There's occlusion and telangiectasia of the capillaries of the fovea of one or both eyes, some exudation. This one, the only thing that I saw that was notable was that it can be associated with systemic or cerebral vascular occlusive disease. But there wasn't really a lot of information in the BCFC, wasn't a lot of information in any of like the other online resources, and I was only able to find a few case reports about type 3.
Yeah, type 3 you can forget about. The one thing, type 3 goes back to the gas atlas, and one of the things about the gas atlas was he had 2 or 3 pages on everything he had ever seen, whether he saw one or saw it every day. And so type 3 may not actually exist.
Okay. And then just some memory aids. This is some of the stuff that seemed useful as far as what's important, seems important in the BCSE and what our Q banks cover. So just think of type 1 as number 1, unilateral. 1 is a smaller number. So think about like smaller kids, like children getting the disease. Coates disease is associated with kids. So type 1 is associated with Coates. Type 2 is bilateral. 2 is a larger number, so it's older people are affected. It's more often temporal, and temporal also starts with a T, like 2. So that was just some stuff that seemed helpful.
It's more trouble to remember all that, because.
That was very good.